Hi, everybody, and welcome. I'm going to get started on the webinar. My name is Jillian Bartlett Espelant, and I'm the Executive Director of the Network Coordinating Office for the Primary and Integrated Healthcare Innovations Network. And I'm very pleased to host one of our learning series on the different topics that are implicated in primary care research. And today our partner site is Beacon, which is the PIHCI site. Sorry, that's a terrible acronym for our network, the PIHCI site based out of Ontario. So today we're going to be talking about PREMs and PROMs in primary healthcare. And for those of you that do not speak fluent acronym, that is patient-reported experience measures and patient-reported outcome measures. So if you didn't know what they were before you signed on, hopefully by the end of the session you will. I will go over a little bit the format for a Zoom webinar. I will read a virtual land acknowledgement, and then I will introduce our speakers for today's panel. So for those of you who have not attended a Zoom webinar before, there is an additional little icon on the bottom of the screen called Q&A. This is where you should type any questions you have for any of the panelists. If you just have a comment, please feel free to use the chat. The chat can be addressed when you do the chat. You have two options. You can send it only to us as panelists. So if you're having a technical difficulty, I recommend you do that. Or you can put all panelists and attendees. So even if you're saying to somebody, great, great presentation, please put it to all panelists and attendees so others can see your comments. If it's a question, use a Q&A. I will be reading those after the presentations when we go into a moderated question and answer session. We don't, in the webinar format, use the raising your hands or having people ask their questions out loud. Although if you have a problem with typing the question, send us a message and I will activate that for you. Si jamais vous avez des questions en français, vous pouvez toujours demander en français. Je vais faire la traduction et la réponse va être en anglais. So if you have questions in French, you can ask them in French. I will do a translation for you, although your answers are likely to be in English, unless our speakers have some linguistic skills I'm not aware of, which they could very well. Okay, so that's how this will be work. This session will be recorded and available on the website afterwards. If there are any links that are mentioned during the presentation, Nick will be posting them in the chat. And I do want to thank all of our network is primarily funded through PIHCI funding, but it's all partnered funding. So I do want to thank our partners who have helped make this possible. Okay, so I am going to, if I can get my other computer to open, got a few screens active here. I'm going to read a virtual land acknowledgement statement that was provided by the Canadian College of Family Physicians Indigenous Health Working Group. So we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. We recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. We respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging new culturally safe relationships, and contributing to reconciliation. Okay. So with that, I am going to introduce our speakers for the day. So they are going to be doing 10 to 15-minute presentations, and then that'll be followed by an active Q&A session. Unfortunately, our first speaker for the day, Dr. Sabrina Wong, will need to leave early because of commitments. She both clinical and teaching that have all of our schedules have gotten a little more chaotic as the pandemic continues to linger. And but I myself, this is a PREMs and PROMs, and Sabrina is going to be talking about a project that is done through the OECD. And I am one of the Canadian delegates for that. So I might be able to field the questions you have for her. We'll see how well I do with that. The other person, the next speaker is Andrew Pinto. And Andrew has been doing some really interesting work on how we measure social determinants. And he will be talking about that work in terms of PREMs and PROMs. And then I'm very pleased that we have two patient partners on the call today. And they always take the position of privilege, which is after the speakers, so they can comment if they wish to on the speakers or just share their experience. And I'm very pleased to have Dr. Olive Branton. I'm sorry, Olive, I probably just messed up your last name. And she will be, she's from PEI, so Prince Edward Island, and she'll be talking about some of her experiences. And we also have Lynn Mansell with us, and she's from Alberta. Sorry, Lynn. And she's actually the official Canadian patient rep on the OECD project. So we're excited to hear about the results of some of her 4:30 a.m. meetings, and that is commitment for you. So we should have a really exciting panel. So I will ask Sabrina if you're ready to turn on your video and see if we can get your slides up and shared. And we will start our presentations.
There we go.
You're unmuted. First successful step.
Okay, now to share.
Yeah, this is always a challenge.
Okay, here we go. Oh, I have to have it on both screens in order to understand what I'm looking at.
Okay, so then check.
Yeah.
We're seeing try that.
Okay, here we go.
You're good to go.
Okay, perfect. Thanks everyone for coming today. And I'm going to talk about patient-reported experience and outcome measures and a project that the Spore PIHCI is involved in. So this is actually an international project, and it's called PARIS, and it means Patient-Reported Indicator Survey. And this is all about measuring patient-reported experiences and outcomes in primary care amongst those who have a chronic condition. And so it is trying to recognize the fact that we need to move to more patient-reported measures as part of what we do in primary care to be hopefully more patient-centered and inclusive of patients' voices in the work that we do in terms of primary care and how we might organize or deliver services. So this is the PARIS initiative. There's an international consortium which is being put together, and you can see their different logos here. A bunch of different people are involved, mostly from Europe, and they all are doing different parts because there's about 18 or so countries that are involved in the PARIS initiative. So I'm going to talk about the overall PARIS initiative, and you'll see what we're doing in Canada. So here is a picture of kind of the very complex timeline, which of course has been slowed down, one, because it's so big with so many countries, and secondly, because of COVID. So we started this process back in 2020, I think actually 2019. And you can see the blue arrow is where we're at right now, where there's translations happening and country roadmaps that are being completed about how each country would be collecting the data. So Canada has been doing this, and we are waiting for some of the testing to be done before we move into a field trial. And in fact, we are supposed to be translating things. We had said we would contribute by translating things into Chinese and potentially Punjabi, and that will happen later this year. And then we will move into what's called a field trial, and this Spore PIHCI will be involved in the field trial. and then will be involved in the main survey. And you can see that it's such a long runway on this one, right? Like, so it in order to get it to go across 18 countries, you need, this is like a 3 to 4 year project. So at the end of the day, the patient reported experience measures and outcome measures will actually be available in multiple different languages. English, many different versions of English. So UK English, American English, Canadian English, Australian and New Zealand English, as well as French. So Quebec French, as well as French, France, French, and then other languages as well, such as Spanish, that's a big one, German, Dutch, and like I said, Chinese and Punjabi, and there's probably more that I'm not mentioning. So an outline of the project is, again, we started in 2019. The larger international consortium has done a lot of work in terms of development of the survey, consultations, putting together a toolbox. They're also putting together the infrastructure to be able to help countries with where they're at in terms of collection of the data, and then management of the data so that it's private and confidential, and then how it would go and be put into one big data repository. And so that all takes time because there's multiple different countries, and it's taking a lot of time in Canada because we have multiple different provinces and territories. So, you know, it does say over here, part 2, execution, starting in 2020, but of course that has been delayed mostly because of COVID and inability to really move things forward in a timely manner because it's not of the highest priority. So part 1 of this is the survey development. So a lot of stuff has been done by the consortium, where they did some focus groups. We actually had Lynn's here and has been part of this international group where they did talk with different patients from across the different countries. They looked at existing surveys, and that was a whole bunch of work to try to map what are the different domains, what are the different surveys, to try to understand what are the best domains that are of interest and are best measured by patients. So some of these are examples would include things like continuity of care, access to care, coordination of care. Those are some of the different kinds of domains that are best measured by patients and not really reported, shouldn't be reported on by other places in primary care. Another one is, a big one is communication. And within the domain of communication, there's things like, is the communication clear? Was it respectful? Those kinds of things. So that is what they did in terms of the existing surveys. They looked at literature, et cetera. And this all informed PARIS surveys for patients. And then there's also a PARIS survey questionnaire for providers as well. And the work that has been done in Canada by people like Jeannie Haggerty, myself, Jean-Frédéric Levesque, et cetera, has all helped to inform what has been some of the content in the PARIS survey. Of course, they would have looked across the world, in fact, in terms of trying to put these together. So in Canada, Dr. Jillian Bartlett acts as our national project manager for the Spore Picken, and so she and myself and other people sort of help to go to these different meetings and to provide guidelines and et cetera on some of the work that's going on. So the next part of this is around data collection protocol. So right now in Canada, this is kind of what we're working on. So we know what our best practices in terms of data collection protocol, and we're trying to modernize at the same time and have a system, as Andrew Pinto has always said, that's going to be sustainable over time. So we don't want this to be a one-time thing in Canada. We want it to be something that is sustainable. So, you know, only going with hard copy surveys in practices is maybe not the most sustainable way to go. So we are also looking at things like collecting patient-reported experience and outcome measures using electronic means, so that it would be integrated with their electronic medical record, and so that the providers can understand what their patient-reported experience measures look like in an aggregated format for people who have replied to the survey from that particular practice. So we're trying to work at this at many different levels. So one is patients participating in practices, and then practices being able to understand what their patient-reported experience measure and outcome data look like in the aggregate. And then we're trying to do this at a provincial level to have some capacity building to do patient-reported experience measures and outcomes at a provincial level in a sustainable format. And then the next one, obviously, is Canada as a country contributing Canadian data from patients. And so we feel like this method and working with the OECD is a good one because it allows for more patients to respond to the survey than things that have been done in the past, such as the Commonwealth Fund. So the Commonwealth Fund, we've gotten about 3,000 patient responses for those kinds of surveys, and then done some statistical fancy work on the back end to weight it and say, okay, well, this is representative of the country. And with the Paris opportunity, we have an opportunity to have many more patients in different practices in provinces to reply. And I would think we're going to come up with a much bigger perspective of patients in Canada than 3,000 people. So this is just a slide on what's going on with the IT infrastructure. There's a lot of back-end work to make this happen. We've done this in the past. Canada, we did something called the Qualico PC survey, and that was all done with paper. So this is what we've been doing in terms of Canada's part. We have some meetings that have happened in Canada, both the national project manager, so Jillian meeting with the international consortium people, but we've also had a few meetings in Canada with the Canadian representatives in the different provinces. So we will head into the field trial pretty soon, and this is a small pilot in each country, and there's multiple different provinces who have signed up to do this. So we're probably going to head into this maybe sometime in the fall or winter. And so the provinces that sign up for the field trial will be involved in this. We'll be looking at the data to validate the model of the survey with that data, analyze the quality of survey operations and pilot results. So what are the learnings so that we can be ready for the bigger rollout of the survey. And so then, yeah, there's a whole bunch of different things that go on in terms of the execution of this, in terms of the IT infrastructure, because it is such a big undertaking. So this is scaling up surveys provided to patients in practices to provinces, and then again to the country level. So there's multiple different people involved at different levels in Canada. And so I'll just end with a couple other slides here. One is the overall planning. So you can see that this is happening, and we're trying to wait right now for some of the French work to be done so that it'll be less work for us to then modify from that French translation. And I think the English one is completed at this point. So we're moving on now to, as I said, the Chinese and Punjabi translations. In the meantime, we're working on sampling, and we've been waiting for the Paris group to settle on their sampling strategy, and they would like the patients to be sampled within practices. And we will be able to do this, but it won't be a sample of it won't be a random sample of providers in the provinces, because of course no kind of list exists of those people. So we'll have to go with a convenient sample of patient of providers who would be willing to be part of this, and then through the providers recruit patients. Okay, so this is just a little bit more. We're looking for about 50 to 100 patients per provider in the field trial, and that's mainly what we're looking for, and we're looking for different practices. So about 5 practices per province at this point to take part. And so this is just another slide around the pre-testing and cognitive testing and how it all is kind of working together. So you can see that the Paris OECD part, they're in phase 1 right now with the English language. And they'll be having a meeting in May to agree on any of the questionnaire changes. And so I'm kind of waiting for this to happen before we start doing any kind of translations in Chinese and Punjabi. So, and then there'll be other translations that happen in June and July, and this is when we know the French translation will be available. So it would be better for us to wait until June or July to have this done so that we have less work to do on our side in terms of Canadianizing the French version of the France survey. Okay, so I will stop there. I'm going to stop sharing now, and I will hand it over to my colleague, Dr. Pinto.
Thank you, Sabrina. So Andrew, if you want to pull up your slides, and we'll hear a bit more about some of the work being done on social determinants in this area. And just to let everybody know, this has been really a key project for creating a very interesting resource for primary care and measuring how we're doing and how responsive we are in Canada. Okay, Andrew, you ready to go?
Sure, thank you so much, and really appreciate the invitation to speak alongside Sabrina and Olive and Lynn and others on this panel. So although we started with a land acknowledgement, I'm based here in Toronto, and I just want to acknowledge that the land that we're meeting and that I'm living and working on is the traditional land of the Huron-Wendat, Seneca, and Mississaugas of the Credit River. And I'm very grateful for the opportunity to be here. And of course, this is still home to many individuals from across Turtle Island. So I'm going to share with you a little bit of the work we've been doing at the Upstream Lab. This is our team here. We're a group of myself, numerous collaborators, students, and research staff. And actually on the call today, I see in our participant list, many of the people involved with the SPARC study are joining as well on this. So anything that you hear from me today, it's really the result of many, many, many people who are working on this. Just to talk a little bit about this topic today. So I wanted to note that there's this intersection between what we often think about when we think about patient-reported experience measures and patient-reported outcome measures around what's been called value-based healthcare, or the idea that we want to have our resources that we're dedicating towards healthcare to be allocated and to where the greatest value is, and that to understand that necessitates a measure like a PROM or a PREM to gather that. How do we actually evaluate the value and who's getting that value? This also, of course, a lot of these ideas emerge also within quality improvement, the idea that we can continuously measure how we're doing and refine our approaches to improve the quality of care that we're providing, but also maybe something relatively new, the idea that we can also use data to drive forward more upstream or proactive care that tackles the social determinants of health, and that we can integrate health and social care and ultimately result in better outcomes and also better experiences for people that's more holistic. And of course, the overarching idea is patient-centered care for all of this, that ultimately we are helping people with the needs that they have and identify. So I'm going to touch on each of these, 3 items, and most of what I'm going to talk about is this newer idea of patient-reported or inferred social measures or data on social determinants. So of course, with PREMs, as we heard, there are many different measures that exist to look at people's experience of care. And I think the work that Sabrina spoke to is going to help us with an international standard around this. And I'm happy to be involved in the Ontario part of that project. With PROMs or patient-reported outcome measures, there's of course a real challenge around what single measure could really be used across many different health conditions. And there are standards that exist from the Canadian Institutes for Health Information and from others around specific conditions. In Ontario here, we have experience using these to look at hip and knee, after a hip or knee replacement, or people's experience of kidney care support. But I think there's a big area of work around what measures really would work and what measures are at that kind of sweet spot between it helps with informing patient care, but also in aggregate helps us understand how people are doing across a whole population, all living with the same condition. So let me turn, most of our attention now to PRISM. So this is from a framework that we published a few years ago around how can health organizations tackle the social determinants of health. And our starting point of this was really data that was collected that brings together routinely collected sociodemographic data, which is really what the SPARK study is about, but combines it with health data, health service data, such as how people are using not only primary care, but also hospital care, emergency departments, and then also community level data on social determinants. So if we put together these 4 buckets of data, it really gives us this rich, comprehensive picture of what's happening with folks. And this can be used to inform patient care. It can be used to inform actions at a practice level, such as even something fairly straightforward, like when do you offer hours of service, or in what languages can staff speak, to changes at how organizations measure their performance, and also overall to informing system change as well. And this is the whole framework, and I think the link was shared in the chat that you can take a look at of how, starting with data, it can influence these different aspects. So if we think about work on collecting sociodemographic data in health, this work has been ongoing in many parts of the system for many years. I know we have some colleagues from the community health centers on today, and they have, of course, for many decades collected robust information on who they serve. But more recently, this is a report that came out about in 2013 from a group of centers in Toronto that started to look at how can we collect data on social determinants in a standard way across institutions. And we were involved with this work. What we found, and this was the first paper we published, that patients, when it was explained why it was being collected, and that was about looking to determine variations in care, that they were actually open to answering these questions. And I think that that was an important finding from the start. We've published a number of other papers that look more in depth at different parts of the questions and how they're worded and how they're interpreted and how people feel about it. We're now, conducting the SPARK study, which is supported by PIHCI, but also from a number of different sources as well. And again, on the line today are a number of the colleagues who are involved with this project, which is involving Saskatchewan, Manitoba, Ontario, Newfoundland, and Nova Scotia as part of this work. I'm not going to go through the actual questions, the current set, just so you get a sense of what do these questions look like, these that collect this PRISM information. So this is, a question on language, immigration status, and the idea is that this would be a standard set of questions that is asked of folks regardless of where in Canada they are. This is the question about race and ethnicity as it is now, and I'm going to come back to this and how it's evolved, but it's heavily based on both the census and also the Ontario Anti-Racism Directorate standard around asking this question of individuals. This is the question about disability status, sex assigned at birth and current gender identity, sexual orientation, and then we have a series of questions about social needs, with the idea that these could be questions that we ask individuals, and then we have something that we can do for them at an individual level, connecting them to services, or it may alter the type of care that we provide people. So around income, housing, social isolation, transportation, and being able to afford utilities. So just on the question about race and ethnicity, I think COVID has, and many people have noted, it's unveiled a huge disparities that exist in our society. One of those aspects has been around how people of different racial backgrounds are treated by systems. And there's been a really growing awareness of both discrimination in health settings, but also systemic racism as well. So early in the pandemic, we released a report on some of our experiences around collecting this data, and also some key recommendations that it should be standard across provinces to allow comparison, but also that there needs to be a strong focus on transparency and engagement with communities. This influenced the Canadian Institutes for Health Information work in this area, and they actually have released subsequent to this a discussion paper and have collected a great deal of feedback, and we're really privileged to be working closely on this as well. This is just one example of how this information has been used during COVID, which is from Toronto Public Health, which showed the very strongly disproportionate impact that COVID has had on racialized individuals during this time. And there are now many, many examples of this. And this information has also been used to inform and build a case for responses. And so, for example, in Toronto, this has been used by the City of Toronto to help target where outreach should be happening, where COVID vaccination clinics should be. It's also been used in Ottawa, in Winnipeg, and in other areas where we see this data actually translating into changes to how we deal with the COVID pandemic. So just some key insights. We think we can achieve a consensus on questions. And I think these will never be perfect, but there is a balance that gets struck between patient, provider, organization, and system level needs. Implementation is really key. It's, I think, the most challenging aspect of this. And I think this ties in with what Sabrina was discussing too, about how we actually collect this data is perhaps really the most difficult thing. And what we found is from our work is that if leadership is supportive, the staff are trained and patients understand why, and there's a trust with the organization, it appears that more patients, most patients will be open to responding to these questions. This is a draft set of key requirements or principles to guide the implementation of data collection, particularly around areas around social aspects, but I think it applies in general. It's of course so important that there's a commitment of the leadership. There's also a really key aspect to ensuring organizations can support Indigenous data governance and sovereignty around this, that there's community engagement, and I'll talk a bit about a framework around this, that there's transparency around what the data is used for and really what the findings are, that there's a commitment to action. We've seen here in Toronto where organizations may collect this data but never gets used for anything. And so there's a need to do that. There's a need to focus on ongoing data quality where we actually look to see, are we doing this the right way? Are we ensuring staff are trained, that patients are clear about it, and that we are actually using it? There's a need to be clear about communicating to patients, and also if people do feel they've been discriminated against, that there's a process to deal with those complaints. And of course, the issue of data security and privacy is really, really key because this is personal health information. One point about community engagement to share with you is to take a look at this community data governance framework from the Black Health Equity Working Group, which is a group that's based in Ontario, and I had the privilege to be part of this group as well. And it outlines these 4 principles of how communities could be involved with the use of this data. And it's I think a new concept to say that data that's collected, not only is there a responsibility to individuals, but that there's a responsibility to communities, particularly if they're characterized in a certain way. So where are we at with this? We're about to embark on psychometric testing and a prospective study with about 200 individuals from across the 5 provinces to further refine the questions and to help inform implementation. We're working with the PIHCI around a validation study as well. And we're also then laying the groundwork for an implementation study to better study how this gets implemented. And of course, I'm hopeful that this fits well with the plans around the OECD Paris project as well. I wanted to end on some very preliminary findings from a qualitative study that we've done that's been separate from SPARC, that actually has talked to about 31 Ontarians around the collection of information on PREMs, PROMs, and PRISMs. So again, most patients reported being comfortable with this data being collected. In terms of PREMs, there was in the interviews we've done so far, and this is just preliminary, there was a strong focus on wait times and people's interest in that being collected. Also, that people were really interested in something that was fairly quick after each visit that could potentially be collected. In terms of PROMs, there was a really strong interest in more in mental health questions and also chronic pain, and that being captured. And then in terms of PRISMs, I think that because there's been a growing awareness in society of systemic racism, there was actually quite a strong support around collecting data on race and ethnicity. And there's again this finding that it should inform the care and that is provided to people. In terms of when this should be collected, a lot of folks shared, it makes sense that if it was possible to collect it before a visit so it could inform the care provided. But of course, people understood it depends. There was a suggestion it should be offered to people in many different ways, and you should ask people what their preference is. There was a range of times of when it should be collected between 3 and 12 months. And of course, there was also that idea, maybe it should be collected after each visit in a very rapid way. when we asked people what would change, there was a strong interest in that this data should inform the care provided and also support connections to services that would help people with needs. And there was a support around the data being shared as with any other personal health information within the care team, but it could be shared anonymously for planning purposes as well. So I'll end there and really just want to say thanks again for the chance to speak about this work, and look forward to everyone's thoughts and reflections on this.
Thank you, Andrew. Oops, flicking on and off. Very interesting. And I see we already have a question that we will deal with in the question and answer session about some of your work. Please don't be shy about asking questions. If you ask anonymously, I will say it's a question from the audience. If you'd like to be identified, include your name. So next we are going to turn to Olive. So Olive, if you want to turn on your camera and unmute yourself and share some of your thoughts with us on this topic, or any topic you want. Because you're a patient partner, so everything's patient-reported experience measures for you.
Okay.
Go ahead.
Well, thank you, Jillian. As Jillian had said, my name is Olive Brynton, and I'm the PEI rep on the Pan-Canadian Patient Council. I have not been on the council very long, but it has been a total learning experience. I am a lifelong learner. I am an advocate for older adults, and I'm also a researcher. So I am involved with a variety of researches that are happening on PEI, particularly those that are related to older adults. And one of the things I haven't heard in either of these presentations is anything around ageism. And that certainly is an area that I am concerned about for older adults. And certainly COVID-19 has brought that very much to the forefront. I work with all ages. I do believe in all ages being involved in issues, but I also believe very strongly that if anyone is dealing with an issue that is going to be affecting a certain population, and in my case, I'm thinking about the older adults, I really think they should be included in an advisory committee, because who is the best expert in what they need? And it really is the older adults themselves who are the expert. Healthcare, I really am pleased with Andrew's work around the social determinants of health. I think as far as older adults are concerned, the social determinants are extremely important in how we are supporting them to age well. I'm not sure anything else that I really need to say. I am just excited as an older adult to be involved in something like this. And if some of the examples of things that have happened in our province, this was due to COVID, was the older adults being so isolated. And one of the things that really disturbed me was the fact that when they had to go to ER, their caregiver was not allowed to be there with them. And we all know that no matter what your age, if you are under stress because of a health condition, there should be another set of eyes and ears there with you. Because if we're under stress, we just can't remember all the things we should say, and we certainly don't remember what's been told to us. So I think this Pan-Canadian Patient Council is going to help make a big difference in how older adults are seeing themselves as being an important part of society, and that they really should be involved in issues that impact on their lives. So I think I'll stop there and we can move on.
Thank you, Olive. I think you brought up a very important point in that this is why we're such strong supporters of patient partners in both research, but in also establishing evidence that goes into care. And I often bring up this example in what we might, so I do a lot of work around treatment decision-making and how people balance quality of life considerations. And it's very clear when you're coming up with these scenarios that survival is how things are ranked in the clinical world. Well, survival at any cost is not really a patient objective. So I think that I'm really excited about how PREMs and PROMs might give a systematic voice to patients. But I think you're right, much the same way that if we don't take into account social determinants, if we don't take into account these perspectives, we run the risk of reinforcing existing biases. So I'm really pleased to have those perspectives for the different projects and in our network. So thank you, Olive, always wonderful to hear from you. So now we'll move to the other side of the country and ask your colleague Lynn to talk to us about some of her experiences, and then we'll come back to the Q&As. Please don't be shy. Okay, I'm going to remind my panelists not to answer the questions in the Q&A box because that means nobody else sees the answer. So, but don't be shy to ask your questions in the Q&A box, and we'll come back to that. Okay, go ahead, Lynn.
Hi, everyone. Thanks to Sabrina and Andrew for their presentations. Excellent. I thought I'm also, as Olive said, a lifelong learner, and recently retired from a long career in seniors health on the policy side. And now I'm on the, and as a caregiver of a mother with dementia, and now I'm on the patient side. I thought I would make a few comments about the Paris survey because, as Sabrina said, I represent the Pan-Canadian Patient Council on the international panel that was advising, that still is advising the survey and the whole process. And I think we were lucky in Canada because we already had a national group that could be represented in those discussions, whereas other countries may not have. And we have just myself from Canada. We have one person from the US and one from Australia, and all the others are in Europe. So they were very interested in what we had to say. So I thought you might be interested in some of the feedback to the survey that is now about to be tested. That represents both our feedback and those of others. First of all, as always, there's the issue of length of the survey. And it's now supposed to be about 25 minutes, but for older adults and perhaps those with disabilities, it might take a bit longer. So it'll be interesting to see when it's tested. As you know, this survey focuses on people with chronic conditions. So that might have an impact. The second thing we talked about was how to reflect the experiences of caregivers in the survey. And after reflection, it was decided that no, that would not be a set of standard questions, but that countries could choose to add their own country-specific questions in that area. I think it's a bit unfortunate because, as we heard, there's the experience of caregivers during the COVID-19 pandemic has been one of the failings, in my opinion, of the health system. Third, as always, issues of wording. I think they've come a long way in terms of plain language, but it'll be interesting to see whether it speaks to everyone in different countries in the same way, so that we have comparable results. Another area that received a lot of debate was whether to include questions about people's experience and outcomes with COVID-19. And it was agreed, in fact, that those would remain because it is a unique opportunity to ask the patients who are most vulnerable about the impact of the pandemic. So that will be very interesting. And the last one was that will be included as well is people's experiences with virtual care and online options. As I don't think that's going to go away after the pandemic. I think there's lots of great examples out there of including patient experience in research. I just wanted to mention one that I'm peripherally involved in Alberta, and that is, and something I'm working on, is the experience of individuals called long haulers, or those with post-COVID-19 syndrome. So people that have very bothersome symptoms long after they're no longer infected. So there is a federal and provincial shared funded multi-province study that Alberta is part of. And the interesting thing about this one is that it focuses on the experiences of individuals over time and their symptoms, their access to the system, their satisfaction with the systems, called CAN-COVID, and it'll involve 2,000 patients from each of the provinces involved. So I think that's a very promising thing. Most of the other research in the area of COVID-19 focuses on medical record data and administrative data. So I'm looking forward to that. And I guess just wanted to comment personally on some of the research projects I'm directly involved in. One of them, as an example, is the ACHRU Community Partnership Program for Diabetes. And I have to say, I'm very impressed with the involvement and collaboration of patients in this particular study. So I think we've come a long way. We still have progress to make in making sure that patients are involved from the beginning. That means the definition of the problem all the way through to the design of the study and the methodology, and of course, translating the outcomes and the knowledge. And that's all for me, Jillian.
Thank you, Lynn. I think it's really fascinating because as Sabrina mentioned in her, and I'll ask all of our speakers to put their cameras on as we go into the Q&A session. What's fascinating is Sabrina mentioned in her presentation, and some of the work Andrew's built on, is these are all internationally validated measures, and yet still there's issues. It's really interesting to me, and I'm sure we're going to discover more, that there's issues with, like, is it really covering what needs to be covering, and the wording. And so yeah, when we get this summer, as we get some of the English and French versions available, and we do, our patient council is actually going to help us with the cognitive debriefing. So they're going to look at these and tell us everything they think is wrong. No, they're going to help us to make sure that we get the language correct and it's understandable. But it's really interesting because these are instruments that people have put a lot of time and effort into validating and making sure they measure what they're supposed to measure, and we're still having these perspectives. Okay, so we're going to move into the Q&A session. Just a reminder, by the way, that there will be a survey to participants after this. Please do fill that in. Also, our next seminar will actually be the Pan-Canadian Patient Council, talking about some of their work. We had this last summer. It was a huge success. Very, very interesting. So that'll be June 22nd. So keep a lookout for that publicity. And so we're going to go into the Q&A session, and we'll go to the first question that Andrew answered, but I'm going to make him answer it live again. And the question was there any way to add PRISMs? So Andrew, if you can remind us what the acronym stands for, into the Paris Initiative across Canada. So I think this is some, and be a little more explicit about what's actually been done as well with this. Go ahead.
Thanks, and sorry I couldn't follow the instruction to not answer it live. So yeah, this was a great question, and the short answer is that indeed there is an interest across the Canadian group to include some aspects of PRISMs or patient-reported and inferred social measures into the OECD Paris initiative. And the advocacy around this is happening at both the international level, where I think Canadians involved are saying, you know, this is really important and we should include this in the international study, but also in the Canadian study, I think a lot of provinces have said that they would be interested in seeing this. I think to explain the acronym a little bit more, the idea is that social factors can be reported by individuals themselves, but they can also be potentially inferred from other markers in our charts, or even things like our postal code, which in Canada has been our default often to using that, linked to census data to help infer what people's social status is. And there's been, you know, decades of work done to use that to highlight inequities in Canada. But I think where the Canadian group is coming from is a recognition that we need to contextualize patient-reported outcome measures and patient-reported experience measures, because these social determinants may actually strongly determine what the outcomes are. And without that contextual data, it can be hard, and we may not actually see the disparities and see the differences. It may just get all lumped together around that.
Mm-hmm. Yeah, and I really do hope that, and if people are wondering whether, you know, the use of a postal code is a good marker, you should be aware that within Canada, there are up to 10 years difference in life expectancy for different postal codes, you know, and that is within the same city. You know, Montreal is a famous example, and where I used to live, you only had to go 5 blocks before you had a 10-year drop in average life expectancy. And for me, coming from a wealthy, developed country, that is just unacceptable differences. And I think this is what we're trying to get at is how do we really target. And I hope that with COVID, and with the involvement of patient partners, we will think of health, not just access to medical care. And so I know that's an ambitious goal, but I'm really hoping our primary care research can help promote that and some of the work being done here. So this is why I'm always very excited to see what Andrew and his group are up to and how we measure this and how we measure it in a way that doesn't become stigmatizing and disadvantage already disadvantaged people. So Olive referred to that when she's talking about ageism. Very frequent in our society to become very paternalistic and patronizing to our older adults, like they haven't managed to accrue some skills getting to the age they have. Instead, we tend to infantilize them and be very dismissive. So hopefully we can stop doing that. All right, thank you, Andrew. And it's always the academics that are not good about following directions on the Q&A. All right, so our next question that we have from Brenda, who is one of our patient partners in Saskatchewan. She wants to know, how do we move the humanity of this session into the front line of how care providers engage with their patients at the point of care? So Brenda always asks the easy questions. So I will, who wants to first go at that? And I actually, if Lynn or Olive want to comment on it, they can, but Andrew or Sabrina? Sabrina's like, that's an excellent question. We could fix a lot if we could do that. Go for it, Andrew. And then I'll toss it over to Sabrina.
Okay, I'll start. And I think this is a great question. I think I guess my initial thought is data can help us reveal and kind of put to really lead to accountability around what often patients experience. So many patients have experienced poor outcomes or discrimination or ageism. What maybe this is going to do is help with data that actually supports accountability around this. I always think of one of our incredible leaders here in Ontario, Camille Orridge, who was is now she was the CEO of the Toronto Central Local Health Integration Network, or a regional health authority, and she was and still is a very strong proponent around accountability of health organizations, and that what data can do if it's collected in the right way, and if it's actually shared, and that there's transparency around it, it can help with holding organizations and providers to account. What I hope could happen is that that's at kind of the organizational level. And one example of this is in Toronto, the Centers for Addiction and Mental Health has for a number of years collected information on the socio-demographics of their patients. And they've recently, a few months ago, they shared how they are seeing differences. For example, Black patients experiencing restraints and other things at a much higher rate than others. And it actually informed their anti-racism strategy then for that center. So I think there's that organizational level. I think it can also help providers. I think providers respond when they start to see, oh, how am I doing compared to my colleagues, but also some of the more qualitative or comments that can be used. We at the family health team where I practice, we've been collecting patient experience information for a while, really led by my colleague, Dr. Tara Kieran, and her work. And it's always interesting, like when you get a comment, both positive and negative. I think one of the things that this can do is it can help providers be encouraged too by positive comments from patients too that they get.
So I'll just add to that, just to say, I guess I would also caution that the data can be used in nefarious or malicious ways. And when we always default to looking at somebody's color of their skin, that's a socially constructed construct. We're already falling into the trap of racism and discrimination. So I think we have to be really careful about the data and respectful of the data. And as you said, to contextualize it and to try to really wrestle as individuals, as organizations, and as a country, how we're going to use that data. And there's just so many examples of where we've collected the data. We know this has happened for years and nothing has changed. And I think we have to be really, really cognizant that if we open this box, we disaggregate the data, that we actually will make changes. And it's more than just getting things into anti-racism strategies. It's really about how are we going to provide equity-oriented care? What are the equity-oriented processes? And I think, Brenda, your question speaks around to implementation, and it's always about how things get implemented. So it's great to collect the data, to find out ways to measure the data and collect it, but it's all about the implementation into practice. And I would say we need to move beyond racism and discrimination, really to equity-oriented processes, and to understand how we can contextually tailor care in a way that makes it safe for everyone. Because there's some things that we just will not collect data on, as Olive has rightly pointed out. And you know, we all know that in society, as soon as you get out of your 20s, literally, you start to get thrown away by society. So you're not wrong. And we just have to figure out ways to implement better. And it's individual implementation, but it's the systemic things as well. And I think, if anything, Andrew and I can work on across the country, it's those systemic factors for sure. As well as we obviously try to implement it in our own practices, but it's really the systemic stuff that's a big deal.
Mhm. Absolutely. And sometimes you're not even aware of it. We're just so used to doing things a certain way. So Olive or Lynn, anything you
Yes.
want to comment? Go ahead, Olive.
Yes, around ageism, I think it's so systemic. It's like part of life now, and we don't realize that the impact of ageism when we are doing anything we do, whether it's providing care. And one thing that always happens is older adults are always seen as being vulnerable. And we really need to look at older adults as having capacities and strengths. And we need to build on what they bring to the table. So I think just being aware that no matter what your age or your situation, you're bringing strengths and capabilities to the table. So build on those.
Yeah, and I think we have some work to do on I think as a society, we preference certain capabilities. And it's just a propagation of where racism comes from, structural racism comes from, just different shades of it. So Lynn, any comments?
Oh, just a general comment. I think primary healthcare from the patient's perspective is built on relationships, and the longer term relationships, ideally. That's the way empathy is built up. That's the way trust is built up. On the negative side, I guess that's not what we compensate our primary healthcare providers for, and that's not what we ask for accountability on. But I think just in relation to the humanity concept, I think primary healthcare has an opportunity, and in a majority of cases is doing probably a better job than other parts of the healthcare system in building relationships.
Thank you. So thank you for that great question, Brenda. We have a question from Allison Dart, who is asking whether the PREMs, PROMs, and PRISMs should be considered for pediatric patients. So any experience using them in clinic? And this is a great question. It's really funny. We kind of ignore, our research tends to be in a very certain focus. I know many colleagues who do not see kids as mini adults or soon to be adults, and we shouldn't really be thinking of that. And one of my work is, of course, giving voice to young adults in treatment decisions. So questions on the pediatric for PREMs and PROMs. I'm like, yes, we should, but I'm not sure the measures are appropriate.
I can start. A few thoughts. One is, in a very pragmatic way, the family health team where I'm based in Toronto, which serves about 50,000 patients, has been collecting this information from all patients for a number of years, since about late 2013. With colleagues, we looked at was there differences by age group in terms of people being offered the survey, and there was big differences on both ends of the age spectrum. So patients who are young children who come in with their parents were often not being offered the survey. Their parents were not being offered the survey, and that's for a few practical things, like you have anyone who's had this experience of going to the physician with your young kids, you're just scrambling to help keep them in line in the waiting room. And so often staff, when we did interviews with staff, they share that I'm not going to offer this tablet with these questions to this busy parent. So there was a bias in which patients were even being offered the questions. The colleagues in the US actually have done a number of studies looking at offering parents of young kids these questions. And if anything, actually in the US, the whole movement around intervening on social determinants has been driven by colleagues in pediatrics. And so there is quite a lot of experience of assessing the needs, the social needs of families with young kids and collecting this information. Here in Canada, you know, the Upstream Lab has started to work with colleagues in pediatrics around the same area, around can we envision the collection of this information to inform care, and understanding that intervening on social needs at the early stage of life has a much bigger effect. And it's really a crucial time of life. Yeah, that's been, I think, the experience. I do think the measures that we use will be different. And there is a body of work around pediatric PROMs and PREMs and that would be applied.
Yeah, so I hope we can see some changes there, because I think the other thing is, you know, people's ability to express preferences and how they've been treated. I mean, the parent could be perfectly satisfied with a conversation, and if it's a pre-adolescent or an adolescent young person, they might be very unhappy, especially if the physician has brought up things that they didn't want discussed in front of their parents, or basically ignored them. I've seen in a lot of my research where even when very articulate, well-spoken adolescents were taking on an adult role, adults would still ignore them and interact with each other to reach a decision. And that was really quite eye-opening. And the way that often people, younger people, are marginalized, much, I think almost probably like, well, this sounds very familiar, you know, put aside, marginalized, or dismissed. I think that's unpleasant for anybody, but I do think it happens a lot with younger people, particularly when there might be differences of opinion between a parent and a young person. So that is a very fascinating area that I do hope more people take up and work with. And there's where we also have a little bit of, we don't have that diversity in our patient count. We do have a younger patient partner, but we don't have the younger voices. So that's another area to work on. Okay, thank you. So we have another question, and I'm just mindful of the time. Okay, and this, Lynn, it's directed to you, but and others can speak as well. Bill Hogg has asked, will the OECD questions be sent to patients soon after an encounter, or do the questions ask patients about their experience of care over the last year? Actually, I think, yeah. So Lynn, yeah, you've probably seen versions, and don't you have like a crazy early meeting tomorrow?
Yeah, I do have the questionnaire in front of me. Well, the time periods vary. Like if you're answering questions about your own personal health or functioning, it's either 7 days or 2 weeks. If it's about your experience with the health system, including primary care providers, it is over 12 months, the last 12 months. And that kind of begs the question, is the last 12 months a typical 12 months? Probably not. So I think what Sabrina said about Canada making a commitment to doing this more than once will be important, because we want to see how the system recovers, how people's experiences differ over time, not just between countries.
Yeah, that will actually be a really interesting challenge, because as Lynn has said, for the field trial, when we're trying to sort out the wording and if this works and if data collection is feasible, this will be, I was hoping it was going to be at the tail end, but it might be right in the middle of still pandemic restrictions and very unusual patterns of care, and a mix of people delaying care and getting telehealth. However, when we then do the full survey with more provincial sites and hopefully territories, will be next summer. So then hopefully we have some time outside of pandemic conditions, but it's not like we're going to have fully recovered.
No.
You know, there was a lot of reorganization of care. There was a lot of stopgap measures taken. There's a lot of people that delayed care, will have new health problems because of, for a lot of different reasons, but certainly the social isolation is going to contribute to the need for a certain amount of care. And so it'll be interesting. And I think the OECD is very aware of this. They're behind on their timeline, but this is actually a good thing because, yeah, the primary care, all aspects of the healthcare system, but certainly primary care was hugely impacted.
Yeah, and I think it's
by-
very valuable to continue on and to collect information that may be unique compared to, say, a few years ago, but it's important to keep asking those questions somehow to see if they change.
And one of the reasons we're working with Health Canada, because typically anything to do with the OECD, Health Canada negotiates, and at times it would be PIHCI working to do the survey. But the reason we're working with them is that we're the only pan-Canadian primary care research network. And it was, we felt it was so important, and thankfully so did Health Canada, that this was done with a primary care group, because it is one of the first forays for the OECD into this type of primary care, where they're looking at care for chronic conditions. And they do have an age restriction. It's 45 and above. So it is not in any of the younger populations. And it's not, it wouldn't be care for other conditions necessarily. So this is something we wanted, and we don't have this information. And we're really hoping, while the information that goes to OECD is very structured and it's anonymous, we're hoping that within the different provinces, there'll be some support to link this to healthcare records, so that we can really have a deep dive and very rich data in terms of how can we improve care, access to care, delivery of care, experience of care. So that is the sort of high level thing, but the timing thing is, it's interesting. But Lynn's right. This is where we really need to see what's working. And I'm hopeful, and people that know me know that not only am I pragmatic, but I'm also an optimist. You kind of need to be to stay in research. I'm hopeful that we'll be able to capture where people have decided to reorganize care, take the opportunity of COVID, deliver it differently, hopefully better, and we'll be able to capture that and see best practices that can then be shared across the network and across the country. So I'm just going to see if we have any more questions. No, we don't. So I'm just going to ask our panelists for last thoughts on this topic, and things I'd like to see going forward, and then I'll do our thanks and our wrap up. So I will do it in reverse order. Lynn, you want to go first?
Okay, I was just going to mention a few of the things that the Pan-Canadian Patient Council is considering in terms of research priorities. So as I said, we feel very strongly that some of these research priorities should be identified by patients and caregivers, but of course in collaboration with researchers and policymakers. So, and again, you're talking about the last year being atypical. We have to go back and review these things to see if our priorities have changed. But certainly from the patient experience, we want to look, as Ontario is already with digital health from the patient perspective. Virtual care, as we've heard, has changed recently, and yet when we talk to patients and caregivers, yes, it's convenient, yes, it is safe, but it may not. There may have to be criteria for when it's appropriate and when it's just not collecting the information that's necessary for assessments. I think, as I mentioned before, relationships between providers and patients, the contributions of alternate and holistic health, and the highlighted areas of concern in terms of healthcare for vulnerable populations. So that's what we will be discussing in the next few months.
Thank you, Lynn, and thank you for sacrificing your sleep to participate in that that particular activity. I feel I'm in a similar boat, but I think that's really above and beyond for you to do that, Lynn. So Olive, any thoughts from you?
Well, this has been a really interesting session, and there's a lot of really good things happening. The one thing that always concerns me is we often will look at a group, or like someone had mentioned, 45 and above. And there's such a difference in what a 45-year-old needs and an 85-year-old needs, or a 105-year-old needs. So we really need to separate out the needs of the different populations. If we're really and truly going to learn more about growing older, we need to know how to age healthy, have healthy aging. And so what we can learn today from the oldest old is going to benefit those coming up through the system, because they know something about what's going on. We don't come with directions. So we have to learn from those going ahead of us, I think, and really make sure that we separate the ages out a bit so we understand what's happening with each. And thank you for the opportunity to be involved.
Thank you, Olive. That's such an important perspective. Andrew, any last words?
No, this is a really interesting, and thank you for the chance to present some of the work that we're doing. I really want to invite everyone to stay engaged with the conversation, because this affects all of our health. And I think it's what we're all kind of envisioning is a system where data that is collected and the data that we derive from the work of healthcare is being quickly and rapidly brought together and used to inform change, so that it's not, 5 years later that we see change, but it's happening in a really rapid, what people have called a learning health system approach. And I think it's exciting. I think there is, like Sabrina mentioned, with this type of work, there's always both the potential but also the peril of it. And something that our group is very mindful of is the potential for this to be misused or to further the divide between people. I think both Olive and Lynn have commented on groups that can be left behind as systems evolve. And what I've been noting down is to bring that lens into our work, and specifically to adapt some of the research we're doing to think more about older adults, to think about people with disabilities, and also to think about people who are not connected to healthcare systems, who don't have a regular primary care provider, and how are we going to ensure that we're engaging those groups and not leaving them further behind as the system evolves really quickly. Part of the work that we do is focused on processing data using new methods within artificial intelligence. And we recently received some funding from CIHR to actually specifically explore the issue of bias that can happen as some of these new techniques, they make use of the data that's available, but if that data is biased, you tend to replicate and actually worsen things. So we're really mindful of that, and really excited to hear about the priorities that were outlined too, because I think they will inform and they align with some of the work that we're doing.
I'm really happy to hear that. Actually, I was reading an article recently about how some of that artificial intelligence and machine learning is actually replicating our structural racism and other biases. And it's like, that's not great. Okay, so I want to thank, we're right on time. I want to thank everybody. I want to thank our panelists and our patient partners. Sabrina did have to leave early, but thank you, Andrew, for taking your time. Lynn, Olive, really always great to have your perspective. Reminder to everybody that June 22nd will be hosted by the whole Pan-Canadian Patient Council, and should be very interesting. You can find these recordings on our website, which is www.sporepickin.com. Look up Pickin and you'll find it. And Nick will put it into the chat, as well as podcasts if you want to hear more from our patient partners. And I would like to thank CIHR, who is the main funder for our network, and all of our partners who contribute funding and time to make the network happen. So thank you very much, and I hope to see you at the next seminar, our last seminar for the year, for the academic year anyways.